Waking you up. I know everyone's had their lunch and you're falling asleep right about now because all the good food is starting to seep in. So I'm trying to wake you up here. So let's, now that we have the radiologists out of the room, let's really talk about cancer because now the people who really know about cancer are left here to discuss it. So my job today is to talk to you about high-risk prostate cancer and the role of surgery and multimodality therapies for managing this disease. So I have no relevant disclosures. This is data that we all know. A large number of men have prostate cancer in the United States, over 180,000 men. And about 20% of men have a problem where they come to see the urologist for the first time and they're diagnosed with metastatic disease at the very beginning. And 30,000 men each year will die of prostate cancer. So this is not a trivial disease, as we all know. High-risk cancers represent the most lethal form of prostate cancer, and yet we really haven't done much to adequately address this problem, the main problem of prostate cancer, which is suffering and dying of the disease. We've done a lot with surgery for minimal risk disease. We've been taking out prostate glands for many years for low-risk cancers. We now have focal therapy for small volume cancers, but we have not really well addressed high-risk prostate cancer. And this goes straight to this point, and that is that we've seen a decrease during the PSA era where about 60% of our patients, 60% used to present with metastatic disease. Now we're down to about 20% over time, so there has been a decrease in the number of patients overall. Yet we haven't seen a change in the mortality rates for these patients over time. And this is, I think, one of the major downfalls or the major tragedies of modern medicine in cancer care, and that we haven't really made a significant impact in this part of the disease process. We know just looking at low risk and intermediate risk cancers that these patients have tumors that often don't progress. These patients have a very similar life expectancy to patients with no cancer whatsoever. And again, we're making minimal impacts in terms of intermediate risk disease, but in high risk cancers, patients have a higher risk of mortality, having regional metastatic disease that requires prolonged androgen deprivation therapy, and the development of distant metastases that leads to bone pain and other subsequent therapies. So the mortality rates are significantly higher in these men, and what we hear all the time when our radiology colleagues and others say, men with prostate cancer will die of something else, well, it's simply not true in this cohort. And this is what screams for screening processes for prostate cancer. We may not be finding this disease soon enough, and maybe we need to be shifting our attention to even earlier diagnosis of prostate cancer if we're hoping to make an impact on this disease by the prevention of outcomes such as metastases and death from high-risk disease. So I wanted to just echo some of what Mark had said earlier about the PROTECT trial that just came out today. Just wanted to let people know what this study looked like. Equally randomized patients into arms of active surveillance, radical prostatectomy, or radiation therapy. And this is a pretty remarkable achievement in the modern era. I know in the United States and in New York, I can't randomize my patients into these categories, so it's pretty remarkable that they were able to have patients randomized into these 3 different cohorts. And what they showed, not unexpectedly, is that the overall survival rates in these patients were unchanged. And if you look at the data, 75% of these patients had low-risk Gleason 6 prostate cancer, so you don't expect a lot of mortality. But what is notable here is that these patients will progress. So these are people who, over a 10-year span, about 20% of these patients developed metastatic disease while on surveillance. So, and what we also know is that over the time of this study, 50% of patients ended up coming off of active surveillance and into active treatment. So these people are not salvageable. And it's pretty remarkable to know that 50% of men on active surveillance ultimately required treatment for their cancers because of progression. And despite this aggressive approach of active surveillance and following patients over time with repeated biopsies and PSA testing and careful, close follow-up, the metastasis occurred in 1 out of every 5 patients who are on active surveillance. And these patients then go on to receive subsequent therapies. So What we also know is that the increases that we see in active surveillance in the clinic, since we have many more patients who are approaching or embracing this process, is going to require us to come up with strategies to more effectively manage those patients who develop metastatic disease, because now we're going to start seeing an increase in that population as well. And this is just to remind us that there has been a massive increase in the number of patients who are now coming and going on to active surveillance protocols. And what's interesting is that even the data that was shown here in the CAPTURE database is the same type of data that was seen in the PROTECT trial, and that is that up to 50% of patients over time come off of active surveillance and end up requiring treatment. So how do we define high-risk prostate cancer? There are many definitions for high-risk prostate cancer that have been utilized. Just simply using a grade, 8 to 10, elevations in PSA over 20, findings of extracapsular prostate cancer, clinical stage T3 disease on examination, and so forth. So this is a very heterogeneous group of people in terms of what we call high risk, that can range anywhere from just under 400 patients in the MSK series to over 2,000 patients, depending on which definition you use. And what's notable is to see the differences in terms of outcomes in these patients. So when we use a simple definition like Gleason grade 8 to 10 or clinical stage T3 disease, this actually predicts for a very high-risk cohort of patients that we see clinically. Other criteria that use things like PSA endpoints, such as PSA velocity, actually predict for a much more indolent course. And a comment was made before about PSA and whether PSA is a decent biomarker or not. PSA is a very good biomarker for identifying patients with prostate cancer, but it is not a very good biomarker for identifying patients or differentiating patients with high-risk cancers, or for evaluating patients prospectively over time in active surveillance. So PSA needs to be used appropriately in the context for which it was initially developed, but to use it in this setting to differentiate patients based on their risk factors is probably not a good use of it. But the common definition that is typically used is for a PSA over 15, clinical stage T2B or greater, and then Gleason 8 or greater. And this is where most of the criteria for most trials comes from. And the SPCG4 trial was mentioned before, and this just goes to remind us that in patients with low-risk cancer, there's really very little improvement in their outcomes with treatment. Patients with intermediate risk, there is some improvement, and these can be statistically significant when we look at things like overall survival and metastasis-free survival. But in patients with high-risk disease, this is where some of the major impacts come in terms of the highest-risk patients and what may be gained. So what we've learned from the SPCG4 trial in this phase 3 study is that surgery does have benefits in high-risk disease, and it improves overall survival and cancer-specific survival. But again, the impact is not as dramatic as we would like it to be. And this is just another way of looking at that same data. So this comes from the Swedish randomized trial that was looked at in a slightly different way by our statistician Andrew Vickers, who looked at the absolute risk reduction. And this gets very directly to Dr. Laguna's comment before about when does the advantage of treatment go away. And it seems to go away not at the age of 65, as shown in many different graphs, but somewhere around the age of 70 or 72, such that interventions beyond this standpoint don't really tend to improve the overall survival of patients because of other competing risks, other competing mortality risks, such as heart disease and other associated aging factors. At our institution, and Dr. Bianco is well aware of this because he's done a lot of significant work on looking at nomograms and developing nomograms at Sloan Kettering, but we like to use individualized risk factors. So instead of putting patients into baskets of high risk, intermediate, or low risk, we'd like to look at individual risk. And this includes our most recent nomogram, exclusionary criteria, obviously, for patients who have had other types of therapy, but looking at age, their pretreatment PSA, primary and secondary Gleason patterns, looking at their clinical stage, and the number of positive cores versus number of negative cores that can help to provide an individual risk estimate for our patients. And we use this risk estimate to separate patients into categories in terms of their 5-year and 10-year risk for cancer or progression-free survival after radical prostatectomy. And so this is what we see when you use these basket definitions of low, intermediate, or high risk according to D'Amico criteria or other criteria, that these patients actually have a very widely distributed risk that overlaps dramatically, especially in the intermediate and high risk categories. And what we've done is we've used low risk as a risk of progression of disease of less than 80%, a risk of progression of disease that is greater than, or sorry, that's risk of progression is between 50% and 80% as defining intermediate risk. And for patients who have the highest risk of progression, those patients who have a 50% or greater risk of disease progression within 5 years. So these categories we believe are slightly more refined than standard criteria that have been used. And when we've looked at this, comparing patients specifically for patients with high risk, looking at radical prostatectomy or external beam radiation therapy, published by one of our radiation oncologists and our group of statisticians and surgeons at Sloan Kettering, we found some surprising details, and that was that patients who had the highest risk of disease progression after treatment were actually better managed with radical prostatectomy as opposed to radiation therapy. And this paper that was published a few years ago in JCO really sort of shocked the prostate cancer world, because this was something that had gone against what we all thought based on prior treatment patterns of patients, and that was that radiation therapy would be a better treatment option for patients with high-risk disease. This showed a very different outcome, and that is that actually surgery was a better option for patients with high-risk disease. And so this bears looking into just a little bit further. So the 8-year probability of freedom from metastasis for radical prostatectomy being 97% and 93% for external beam therapy. And after we adjusted for all of the factors that people talk about in terms of case mix, comorbidities, amount of disease, and so forth, surgery was still associated with a reduced risk of metastasis with a very high hazard ratio and a very high statistical significance. And this was also similar for patients in terms of prostate cancer-specific mortality. So there is a major benefit to treating patients with high-risk disease with surgery in terms of survival and cancer-specific endpoints that we care about. Well, what have our colleagues in radiation oncology done? Well, they've taken this a step further, and they've said, well, we need to really find out how we can augment treatment effects with radiation therapy. And so several trials have been done combining androgen deprivation therapy with radiation therapy. Now, as many of you know, androgen deprivation therapy is used as a sensitizer for prostate cancers. So the idea is that prostate cancers that are treated with radiation will upregulate or activate pathways of survival that involve androgen receptors. So this is a heat shock protein or a danger signal that when prostate cancer cells get into trouble, they use the androgen receptor pathway to survive. So by knocking down or blocking that pathway, you can conceivably improve the sensitivity of prostate cancer cells to radiation. And yet these patients are often maintained on androgen deprivation therapy for 2 or 3 years after radiation treatment. And what they showed in large randomized trials is that androgen deprivation therapy in combination with radiation is a benefit and improves survival and progression endpoints in patients. But significantly, what is worth noting is that in those patients with low or minimal comorbidities, the greatest amount of benefit is seen. But what we see for patients with severe comorbidities, that there may be a price to pay, and that is that we know that androgen deprivation therapy can increase patients' cardiovascular risks, risks of liver dysfunction, risks of bone loss. And in this group of patients who have severe or moderate comorbidities, we actually see the opposite effect, and that is that the use of androgen deprivation therapy in long term actually increases the patient's risk for mortality. So this is something to bear in mind when we start talking about combining therapies, and that is that there are some patients who will benefit and others who will not, and this bears further investigation. And again, this has been confirmed with several other phase 3 trials throughout the radiation literature, so this is now considered standard of care. What's interesting to note is that despite this, looking at the use of hormone therapy plus radiation therapy compared to radiation therapy alone, there's a benefit. But when you look at surgery in the same groups of patients who would be managed along these pathways, surgery still appears to have a better overall survival probability in this paper that was just recently published last month in Urologic Oncology. So this pathway has made its way into the NCCN guidelines, as we all know, for high-risk disease. Here are the different categories we talked about before in terms of patients, the basket categories of high risk. But with external beam radiation therapy or with brachytherapy, all of these combine androgen deprivation therapy. Yet with surgery, our outcomes have always, our approach has always been the same: radical prostatectomy plus pelvic lymph node dissection. And our strategies for high risk are really reactive, meaning after we remove the prostate gland, after we remove the pelvic lymph nodes, based on what the pathology tells us, we then stratify patients into categories in terms of their management and follow-up. For the patients who have lymph node positive disease, the pathway is often androgen deprivation therapy. For patients who have positive margins but lymph nodes that are negative, the pathway often involves salvage radiation therapy to the pelvis afterwards. The question is can we improve upon these outcomes? Can we do the appropriate prospective trials? So to look at this in terms of how we can leverage surgery. So what does surgery obtain or attain that other treatment modalities do not? So how do we leverage these advantages? One is that surgery provides immediate local control. By removing the prostate gland, there is no residual cancer to worry about in terms of tumor recurring inside the prostate gland. This is something that we worry about after radiation therapy or ablative therapies, that cancer may return inside the prostate gland and that may serve as a reservoir for cancer cells to metastasize elsewhere. So we can achieve very aggressive local control, regional control. We can look at the histologic evaluation of response. So if we're talking about neoadjuvant trials of giving drug therapies before surgery, we can look at the histologic evaluation of what occurs in that setting. And biochemical monitoring for patients after surgery, as we all know, is very, very straightforward. Your PSA should be undetectable after an operation that's successful at achieving an R0 resection, that is complete resection of all tumor. And so there's less confusion in terms of the biochemical monitoring in these patients. So obviously our thought process, the thought process in terms of how cancer behaves in patients has dramatically changed over the last few years. As we've learned more about genomics, we've learned about the ideas of subclones of cancer cells, where they come from and how they traffic inside the human body. So tumors that start off locally will send local metastases nearby. Those local metastases may traffic to other sites in the periphery, and those other sites may actually traffic back to the prostate gland after progressing in the periphery and then migrating back. Treatments that involve just hormone therapies in general can handle some of this heterogeneity or tumor heterogeneity, but it doesn't handle all of it. And that's where things like surgery, in terms of interrupting this process of removing the primary tumor and avoiding the trafficking process, may come into play. And so, again, looking at the issues of improving survival in these patient population, most recently we saw this paper that just came out last month in 2016. So not just looking in patients who have localized high-grade cancers in terms of using androgen deprivation therapy plus radiation, but this is the use of androgen deprivation plus radiation in patients with existing metastatic disease. So a completely different ballgame in terms of what we're dealing with. And what this study showed, which was a retrospective study looking at the National Cancer Database of over 6,000 patients who had metastatic prostate cancer, in those patients who were treated with androgen deprivation and radiation therapy, those patients did better than patients who were treated with ADT alone. And so this suggests that there is something that improves these patients' outcomes above androgen deprivation therapy alone when you include local control of the tumor, that is, local prostate control in the pelvis. Prompting this editorial written by Chris Logothetis and the group at MD Anderson to say it's time to really start to readdress this question of whether a treatment paradigm to target the interaction between the prostate tumor and the metastases is now at hand. A time for us to reevaluate the use of cytoreductive procedures such as surgery or radiation. And how do we achieve this? Well, in surgery, one of the advantages that we have is that we also attack the pelvic lymph nodes at our center and at many others for patients with high-risk disease. We don't just remove this sort of level 1 group of lymph nodes, but we remove a very wide echelon of lymph nodes, or a very wide area of lymph nodes in the pelvis. And in some cases, we're now extending this up into the retroperitoneum and into the pelvic lymph nodes for patients with high-risk disease. We all know some of the data that looks at this in terms of this is the long-term outcomes in patients with lymph node metastases who have not received adjuvant hormone therapy. So these are patients who have been left without any systemic therapy. And we know that the long-term probability for metastasis-free survival and overall survival and cancer-specific survival can be quite good in these patients when they're treated aggressively with surgery alone. How can we look at this data where we look at patients who actually have a long-term, over 10-year disease-free survival in over 25% of patients with small volume metastases? We can either take credit for that as surgeons, or we can say this is disease biology. We don't necessarily have the tools to fully understand what this looks like, but clearly there has to be a benefit that these patients are seeing from aggressive resection in nodal metastases. This is just a slide to remind us that, at MSK we're not the only ones to be doing this. Obviously, the group under Dr. Studer and many others have looked at the distribution of lymph nodes, just showing that the lymph node distribution in the pelvis can be wide in many different areas, something that we can't necessarily go after with just minor templates that we're doing. We have to go much wider to take out hypogastric lymph nodes, obturator nodes, external nodes, and in some cases even higher. But what's also notable, and this is something that I wanted to give you all just a little peek into what we have at MSK and in what some of our little private data looks like. This is something from the Amplio data set. So at MSK, I can log in at any time and I can pull up a graph such as this, and it may show me where I am in relation to all the other surgeons in our group. And this is a generic slide, so we can't identify anybody here in terms of individual surgeons, but these are the results of what we see, that there's a tremendous heterogeneity in terms of the number of lymph nodes that we take out. So all lymph node dissections are not the same. All surgeons are not the same in terms of what they achieve in terms of removing lymph nodes. So even in high-risk patients, some surgeons have an average of 12 lymph nodes that they take out, others an average of 22 lymph nodes. And the amount of lymph node involvement that you would see is dependent on the number of nodes that you take out, and indeed even upon your surgeon. So even this surgeon who's taking out more lymph nodes is just on par with the same surgeon here who's taking out fewer lymph nodes. But as we get to much higher numbers, there's something about this surgeon here that they're removing more nodes and finding more cancers in those lymph nodes. And this is controlled for the case mix in terms of grade of cancer, amount of cancer, and so forth, utilizing our nomogram prediction criteria. So we looked at this recently, just last week at Sloan Kettering, to say, what is this heterogeneity and why is surgeon a factor? Surgeon should not be a factor, but this is something that we have to realize that surgeons are a factor in terms of what we can achieve. And you might say, well, what's the big deal? So this surgeon takes out more and he finds more lymph nodes and this one finds less. Is there anything that's particularly therapeutic about this? And this is probably where this data looks sort of the most unusual, and that is same group of surgeons, same data that we're looking at. Now we're just simply looking at their 2-year BCR reporting rates. So again, more nodes being taken out. It looks like there's a lower rate of BCR recurrence in these patients where more lymph nodes are being removed. For patients who have, or for those who are taking out fewer lymph nodes, a much higher rate of BCR or biochemical recurrence is occurring in patients. So this is a pretty big factor difference when we control for disease factors, an absolute difference of over 16% difference in terms of BCR rate at 2 years. And that's something that tells us that unlike medical therapies and unlike radiation therapies, where with medical therapies we give a drug and that drug is a fixed dose and the patient receives that drug, or with radiation where there's a radiation field that's provided and it's a fixed dose of radiation, in this setting the physician or the surgeon is actually a therapeutic variable that we have to take into account. So these are things that we have to keep in mind. And this is what we tried to address with our recent update to our nomogram, looking at pelvic lymph node dissection, showing that actually our lymph node positivity rates are much higher than what we had previously published, because now we're pursuing wider and wider lymph node dissections in these patients. And this is something that we talked about earlier today, and that is what is the utility of biochemical imaging, so things like choline PET scans, and where is this going to take us in the future in terms of lymph node dissections. So this is a lymph node that's way up in the hypogastric chain, actually in the common iliac chain, high above the right common iliac lymph nodes that we normally would take out. And in fact, on another scan, you'll see that this is actually up in the paracaval lymph node chain area here. So during our resections, we're now, after looking at choline PET scans and finding these evidence of more extended lymph node involvement in patients, we're extending our lymph node templates even higher. And I think that the future will tell us that, that we're going to get better and better at removing lymph nodes based on radiographic evidence of what we find on biochemical, on biologic imaging. But what impact this may have on patients' mortality rates and progression-free survival is yet for us to understand. This is too preliminary to know. So in terms of where we stand in terms of developing clinical trials, this is Howard Scher's disease states that he talks about the non-castrate prostate cancer setting, and then in those patients with castrate-resistant prostate cancer. So we're really talking about, in this setting, the patient who has clinical metastases in the non-castrate state, where the tumors are still responsive to androgens. How can we use surgery as in combination as a multimodality therapy to eliminate or relieve or control disease manifestations that might be present, and to prevent new disease manifestations, to prevent progression of disease. And so how do we look at a patient such as this, a patient who has an intact primary, who has osseous metastasis here in the pelvic ischium, who's incurable by any monotherapy. Surgery alone will not cure this patient. Radiation alone will not cure this patient. How do we address this patient who has a local tumor or a local prostate intact and a separate site? And we're starting to consider these as a patient with two different diseases, a patient with a localized disease process and a patient with a secondary disease process that we may have to manage separately in a combination way with multimodality therapies. Why would this work? Well, we know that cytoreduction is effective in other advanced malignancies, very well described in renal cell carcinoma, well described in ovarian cancer and in colon cancer, and indeed in things like other tumors such as testicular cancers, where we combine chemotherapy with cytoreduction, with removing the residual disease with surgery with an RP-LND. So the survival advantages are clear when cytoreduction is utilized in these different settings, and it may also play a role in patients with prostate cancer. This was another paper looking at SEER data showing a survival benefit for patients with metastatic disease who had undergone local therapy. So this is just drawing data out of SEER, a large national database, to see what's been going on in the community. And when they've looked at this case series, patients who've had radical prostatectomy have had an improved 5-year overall survival and a 5-year disease-specific survival. And the same is true for forms of radiation therapy as well. So while there may be major problems in this data here in terms of the case selection which is going on when they're trying to compare no surgery or radiation to these groups and why these patients received treatment and these did not, there's evidence, or at least hypothesis-generating data here, to suggest that there may be a role for surgical interventions in these patients with metastatic disease. So where do we stand in terms of where to go? Well, we could follow our colleagues in radiation therapy and combine androgen deprivation therapy with surgery, but we know that that's been done already. This is the follow-up to Bill Fair's trial that was started at MSK many years ago, looking at the outcomes in patients who received neoadjuvant androgen deprivation therapy for 3 months prior to radical prostatectomy compared to radical prostatectomy alone. At 8 years of follow-up, there was no difference in the biochemical response rates in these patients. We saw less margins positive, we saw smaller tumors, we saw fewer nodes being positive, but it did not impact overall survival in these patients because survival was quite good overall in this patient population. And several other groups have done the same, and this just lists all the other studies that were summarized in terms of trials looking at androgen deprivation therapy prior to surgery in patients with high-risk disease, and there's been no significant improvement based on this. And you might say this makes some sense in this setting, because unlike radiation therapy, where androgen deprivation therapy is used as a sensitizer for radiation, in this setting, surgery already removes the localized form of the disease. It's the metastatic disease outside of the surgical sites that lead to the ultimate outcomes that these patients suffer from. So this just looks at the most recent study that came out of the group from MD Anderson and out of Boston, and a combined group of 4 different centers, including University of Washington, where a neoadjuvant trial was done using LHRH alone. Again, this is our standard androgen deprivation therapy, compared to LHRH plus abiraterone. These patients, however, instead of receiving 3 months of therapy, received up to 24 months of therapy before and following radical prostatectomy. 30 patients were randomized in each arm. 12-week biopsy was done to look at intraprostatic versions of testosterone that were evident inside the prostate gland, and then radical prostatectomy at 24 weeks allowed for pathologic staging and looking at hormone levels and so forth. What we don't have in this trial is any readout in terms of survival and metastases endpoints, and those are awaited because this is preliminary data. But what this shows is that a complete response rate was found in up to 10% of patients who were treated with this approach, and that there were significant changes in the intraprostatic forms of androgen that were seen inside the prostate gland. And this is data that Howard Scher and others at our place are looking at very intently, because there's interest in pushing the envelope in terms of what we can utilize in terms of neoadjuvant therapies with androgen deprivation therapy, with severe intense forms of androgen deprivation therapy combined with surgery and possibly immunotherapies as well. This is just some of the details of some of the data from Sloan Kettering. This is unpublished data. This was internal information that we've looked at on our own. We have about 20 patients altogether who've had M1 disease who've been treated. Many of them have received combined androgen blockade, plus or minus abiraterone. The duration of treatment is listed here, many patients being treated for over 6 months. And the time between initiation of treatment to surgery is about 3 to 4 months, and then looking at biochemical recurrence and so forth afterwards. Pathologic outcomes showing that we still have persistence of extracapsular extension in up to 85% of patients, seminal vesicle invasion, evidence of advanced cancers. Node positivity still an issue in these patients, some with large volume nodal disease, but other patients who are completely N0. Complication rates being low. And in terms of continence at 12 months, and we define urinary continence as being completely free of pads after their surgery, so up to 75% of patients at a year out completely pad-free, and 85% at the time of last follow-up. Local recurrences have been 0. Just shifting gears a little bit more to look at other forms of therapies that can be utilized as opposed to androgen deprivation therapy. This was the data from Eric Klein, looking at the combination of chemotherapy plus androgen deprivation therapy, showing that when combining the use of docetaxel along with hormone therapy, that an improved cancer-specific survival could be achieved. And this was the data which led to the supporting information for the randomized neoadjuvant trial, the CALGB 90203 trial. This was James Easton's trial that was a multi-center study randomizing patients to standard of care, which was surgery alone versus docetaxel and hormone therapy followed by surgery. This trial has now completed its enrollment, and we're now waiting for 1 more year. We should have the initial results coming out, the 5-year data from that study. And then finally, just looking at this is another European trial that was looked at, also combining ADT therapy with docetaxel, and showing that there may be evidence of a long-term survival advantage. So this is what we may expect in the future when the readout from the 90203 trial comes out. So I'm going to end there. Sorry, I'm trying to get through one slide here. So the summary is just this. High-risk prostate cancer, it's a heterogeneous disease, and we need to be very clear about what we're talking about when we define what high-grade cancer is or high-risk cancer is. So you need to be very clear on the definitions that you're utilizing and how that may affect your outcomes. The predictive models that we have that are based on factors such as age, PSA, and grade, they tend to perform well, but they need to be refined. And there's clearly going to be better data when we start combining fusion biopsy data that more accurately defines the cancer, imaging criteria such as MRI and biologic imaging, and possibly even genomics or serum biomarkers such as circulating tumor cells into our definitions of what high risk means. Surgical intervention all by itself, without anything else, appears to be favorable for these patients and will favorably impact the natural history. And the role of extended node dissection appears compelling, but is not yet proven. And it's going to take a huge effort for us to try and go down the road of doing a trial in lymph node dissection for these patients, because it's very hard to randomize patients to no lymph node dissection versus an extended lymph node dissection. Even though people are trying to do limited dissections versus extended dissections, I'm not sure we're going to have a good answer in the near future for high-risk disease. Neoadjuvant trials have already accrued, so this is the docetaxel trial we talked about. Newer trials are underway. The endpoints of survival and progression are interesting, but we need to have better surrogate endpoints that give us a faster readout. And the question of things like complete response rates, in terms of what we find, whether those may be appropriate surrogate endpoints for us to use going forward, are things that are being debated at the moment and controversial. New technologies in surgical visualization, such as preoperative imaging and intraoperative fluorescent imaging, are also being evaluated to help us more effectively treat these patients. So in selected M1 prostate cancer patients, radical prostatectomy, at least in our hands and in the group and in other published data, is clearly feasible and well tolerated. Patients can be continent after these procedures and do well, and it has acceptable low rates of complications. And ADT can be discontinued in limited numbers of patients without signs of disease progression and short-term follow-up. So where we're going is that we really need to establish a series of treatment paradigms that use acceptable endpoints for our clinical trials. And those may be we believe at looking at the time point of undetectable PSA in the non-castrate testosterone setting. So that means if you do combine androgen deprivation therapy with surgery in the setting of a patient's recovery of testosterone, how long do they stay with undetectable PSA levels? It's a clean binary value that we can look at. And even though survival has been considered a gold standard, detectable PSA indicates treatment failure when the goal is disease eradication. And ADT may be utilized in the future to maximize apoptotic response. However, we believe that using it to act in the form of maybe releasing tumor antigens to enhance immune response, use additional therapies for durable anti-tumor response, and then including radical prostatectomy may help to provide durable control and improved outcomes for these patients. So this is the road ahead of where we're looking right now, and I think other groups in the U.S. are also looking in terms of developing prospective studies. So with that, I'm sorry for the length of time, but I've really enjoyed having a chance to talk with you all today, and if there's time for questions, I can take them later. Thank you. Do you want to wait?
So John, excellent talk. I think that one of the most intriguing parts of your talk was the fact that it seems like in older men, right, the paradigm of radiation plus hormonal therapy really is not the best option. So what do you think it will be the best way to court out those guys that say 70 and older who have a Gleason score of 8 and who have disease that's, let's say, T2A, T1C? How do you think we should manage those folks?
Well, I think the data clearly shows that there's no clear advantage of giving those patients androgen therapy in combination with radiation.
Right.
So I think you may get to the point where you say in patients with significant comorbidities that those patients are really at increased risk of other forms of mortality, right, especially when you give androgen deprivation therapy, and that in that cohort of patients that radiation therapy alone would probably be a better decision than using androgen deprivation in combination with radiation therapy.
Or surgery.
Or, well, surgery in patients with a lot of comorbidities. I think we're talking about people who have a lot of medical problems. But there's another trial, as we all know, there's the RTOG study. There was, I think it was 92-213 or something that was published a few years ago that looked at the 10-year outcomes. We're waiting for their 15-year outcomes to be reported on, and that may also show, even though the earlier trials showed that there was an advantage of androgen deprivation therapy with right, radiation therapy, it'll be interesting to see if they segregate their population similarly to the way that D'Amico did, and if they look at those with high comorbidities, whether there might be a disadvantage to giving ADT in those patients. So I think we have to really wait for those results and see what they show.
¿Alguna pregunta en la sala?
What about focal therapy for those patients?
Focal therapy. To address the question of focal therapy, so we are starting a trial so we distinguish between focal therapy and what we call partial gland ablation. So the process of ablating cancers in the prostate gland in terms of using a different modality between surgery and radiation as ablation options and doing partial ablations for prostate cancer is slightly different than focal therapy. Focal therapy being addressing a small focal lesion, whereas ablation is trying to destroy the cancer. And can that process also release antigens? So we actually have gotten approval from Merck to combine a form of ablation therapy, which is 2CAD therapy, so VTP therapy, with their drug pembrolizumab. And so that's going to be a trial that is going to be used in patients with intermediate to high-risk disease, so Gleason 4+3 or higher, bilateral cancers, in which case we ablate one side of the prostate gland in combination with an immunotherapy. And we have preclinical data to suggest that there may be a way of generating a systemic response in those patients that we may be able to utilize not only to treat the other side of the gland, so we don't have to worry about getting all the cancer treated in the prostate, because that's the thing we worry about in focal therapy, which is missing other tumors. If we can generate a local response in the prostate to mop up those small cancers, that would be nice, but also to generate a systemic response against metastatic deposits.
Terrific. Thank you, Dr. Coleman.
Thanks.